right, here we go. So the conflicts have not changed. And I'm going to be talking about risk models. So I think opening this up, I think the first thing that we need to acknowledge, as Tim and many of the other speakers have said, is that the outcomes both in AMI and AMI cardiogenic shock have clearly evolved over the last 2 decades. And if we're going to try and develop risk prediction models, we need to use contemporary information, contemporary data sets. I think that's right off the bat. So what are the challenges? And I think we've been discussing this morning, many challenges when we're trying to identify a handful of criteria that will help us in determining, let's say, mortality in hospital at 30 days. So, the question here is, what do we measure? When do we measure it? And how do we measure it? And again, there are multiple additional things that are being developed that are going to add to this equation. So the challenge is, of course, this is a very complex patient population, the stage of shock, how sick these patients are at the time of evaluation, the extent of end organ damage, very heterogeneous etiologies, as we've discussed. Is this a mechanical issue? Is this AMI, cardiogenic shock, heart failure, et cetera? And of course, there's multiple measures. Clinical, hemodynamic, invasive imaging, biomarkers, and they only continue to grow. And I think the other issue here is the dynamic change over time. So we tend to evaluate patients, and when we develop these risk models, it's done at a single time point, but of course it changes over time, and it's very dynamic. It changes very quickly. So when we're talking about risk models, I mean, just graphically, we've all seen these patients, we've all taken care of these patients. How do we integrate everything that is going on with this particular patient in a statistical model, try and identify a handful of variables that are going to predict outcomes, predict mortality? So what I'm going to do is I'm going to walk you through some of the risk models that are out there. I had to cut this short because of time, my 8-minute allocation. But just to know, there are about 20 models out there to look at. But you'll see sort of a recurrent theme here. So I'm going to start with the IABP Shock 2 score. This was looking at 30-day death. It was derived from the randomized clinical study, so it's a relatively homogeneous patient population, patients with stage C to E class. You can see that it's based on 6 variables, and when classifying based on these variables, you can see that it really kind of stratifies patients based on outcomes. And I'm going to be talking about C statistics. That's how you measure these risk scores and how well they do. In this particular setting, the C statistic in the validation data set was 0.79, pretty good. Anything above 8 is good. Anything above 0.9 is excellent. Anything between 0.6 and 0.8 is moderate, and anything below that is poor, just to kind of set the stage here. Here's another risk score, the CARD shock score. It's looking at in-hospital mortality. You can see that it's based on 7 variables. It was derived from a much smaller patient population of 219 patients and mixed cardiogenic shock. So this includes ACS and non-ACS patients, and they were recruited in 2010 to 12. So, in terms of the timing, maybe a little bit old. And again, if you look at the C statistic here in the development cohort, it was excellent, 0.85. So you'd say that was great, right? But the issue is when you validate these in external data sets, then the ability to predict outcomes actually drops significantly. And now we're looking at C statistics in the range of the mid 0.6, 6.5, 6.8. It's really kind of moderate in terms of their ability to predict outcomes. You have to look at the patient population to see if it's relevant to your patient. It's certainly easy to use. You can go on the internet and just kind of plug in the numbers and you'll get your score. Here's another one, the cardiogenic shock score looking at 30-day death. Again, it's based on 12 variables, so increasing the number of variables. They're all very intuitive. The relationship between the score and mortality at 30 days is almost linear. It seems to be, it performs extremely well in the development data set. But take a look at the C statistic here at 0.74. It's modest. And then when you validate it in external data sets, again, that drops even lower to 0.67. So again, very moderate. And you can see that it performs actually better in acute myocardial infarction, not so well in non-AMI. Here's another score called SAVE. This is developed from an ECMO patient population. Large number of patients, 3,800 patients. Again, mixed cardiogenic shock between 2003, 2013, relatively, old in terms of the patient population. We're looking now at 19 variables, a little bit more complicated to calculate. And again, if you look at the development data set, the C statistic was 0.68. So again, very modest, not great. And again, when you take it to external validation, then that drops even further. So this is the problem with these risk scores. There's really nothing that's perfect out there. This is kind of interesting because it's a single center experience from Columbia looking at 70 patients with AMI cardiogenic shock, where they essentially took the patient population and tested 20 different risk scores. And again, I think it drives home the point. If you look at the range of the C statistic, it ranges from poor, 0.49 to 0.79, so up to modest, but nothing really better than that in terms of being able to predict outcomes. So I think that's sort of the challenge with what we have in terms of these risk models. So, I think the single most important step forward in trying to classify our patients and risk stratify our patients is the SKY shock classification. As you know, this was initially published, I think it was 2017, and then an update was published just a year ago, and I really encourage you to read that paper in JSky. And what this does, this is not based on statistics. There's no regression models or anything like that. This is really based on clinical criteria to be able to stratify these patients. It's easy to do. It can be done at the bedside, and the beauty of this classification is that really it's meant to be simple to implement. If you take a look at that paper, there's a very nice table that is here that kind of outlines all the criteria that go into classifying the patients, and again, very easy to use. So what's really wonderful about this, and I wouldn't call this a validation, it's being used in multiple data sets across different disease entities and etiologies, and you can see that within each one, it predicts mortality. For each stage, you have an increase in mortality. What it also shows is that you have a lot of variability from patient population to patient population, which really speaks to risk modifiers, and I think they address that in their most updated document, where they're pivoting not just from a staging of the patient population, but now to risk prediction. Again, this is not a risk model. But they're now suggesting this three-axis model, where the staging is one component, but phenotyping and the etiology, as I mentioned, is a component of the prognosis, as well as the risk modifiers, and we spoke about that this morning. I would argue the treatment type, particularly mechanical circulatory support, is another sort of axis, and I think the last dimension is the trends, the dynamic changes in that patient population that need to somehow be integrated if we want to really understand the outcomes of our patients. So my takeaways, I think, current risk models are way too simplistic. We're trying to take something that is so utterly complicated and simplify it. And I think what that's done is that we do have risk models, we can use them, but on average, they don't, all in all, I don't think they really perform very well, and I explained the reasons for that. I think the sky shock staging and classification is, again, a huge step in the right direction. It's clinically derived, it's intuitive, it's certainly broadly applicable across populations. It's been adopted pretty rapidly. It benchmarks patient status during a dynamic course, and it's consistently predictive of mortality across multiple populations. And as mentioned earlier, I think the future really is in integrating all these parameters using artificial intelligence. I really don't know how we can simplify that more. I know there's ongoing work in that space, and several talks, actually, I think, during this session. I'm going to close shamelessly on this. I'm the editor-in-chief of JSky, very proud to be leading this journal. There is a call for papers right now where we're going to be publishing this issue, this special issue, looking at the role of artificial intelligence in cardiovascular interventions, and we're very interested in this space and this work, so please submit your papers. Thank you.
One comment.
Great talk.
Yes.
Fantastic. And like you brought out, there are so many risk models, but unfortunately, there's very little external validation of all of this. Sky shock probably has more validation than the others, but integrating the molecular omics with this is going to help, and for that, you'll need quantum analysis of data, because the data has become so big that an individual to make a score is going to be very difficult. But still, we need much higher rates of differentiation and coincidence rates for this to be clinically relevant.
Yeah, I mean, I think the models, the risk models that are out there have been designed to be very simple, but you can't do that. I mean, I think we're looking at patient populations that are these patients are just so complicated, and there's so many variables in there that are going to impact outcomes. And I just don't think you can, distill it down to 5 factors to say, this. I mean, it works to a certain extent, but, you're really not going to be able to be very precise. And I think that's the issue.
Because the day we develop a good cardiogenic shock system, the validation model, that day all the debates about randomized controlled trials and everything in cardiogenic shock will go away. But till that happens, we will still struggle with registry versus randomized trials.
Right. Yeah, I think standardizing, I think that's the value of the staging, the Sky staging, right? Is because you're using, it's a consistent language. I mean, it's a little bit, thinking about cancer staging, right? And which treatment goes to which patient. I think it's along those lines, but I think, Naveen, you pointed out earlier, there's risk modifiers, right? So it's not necessarily, you could have a stage B, let's say, that had a cardiac arrest that in fact would have a much higher mortality than a stage C. So I think, it's complicated, and I think we need to build, it's a good foundation, we just really need to build on that foundation.
Tim.
Thank you.
Yeah, just a really quick comment. So first of all, outstanding talk. But I think, what are we trying to do with risk scans? So I think this helps you very little when you have a patient come in through your emergency room or in your ICU who you're taking care of. That's not where it helps. I think the benefit of having scores like this and doing it is as we're designing clinical trials so that we can compare similar patients. And I think it's also really important for your own registries so that you can see how you're doing, how your standardized protocol doing. So that, I think, makes a difference. Naveen has done a terrific job of adding to the Sky Shock, but a really important part of shock is that it's dynamic. So your risk score, 1 point, might be totally different in an hour from now, and this time course of what's happening, so deterioration, people are on that scale, is where it really predicts. But I'm not sure it'll ever help us for an individual patient because you don't know. And then the final point is the biggest unknown is out-of-hospital cardiac arrest, which is more than half the patients. And of course, the thing you cannot predict is who's going to wake up and who's not going to wake up. And so I think that's a challenge from a help me with this individual patient. I'm not sure it ever will.
I think, I think where this becomes helpful, I mean, and again, I think AI is going to help, is tailoring therapy. I mean, we're in the dark ages in this space. I know this symposium is so important because we're gaining more information and knowledge and trials, et cetera, but trying to tailor therapy to guide outcomes is, I think, where we can go with this, and where it's very early stage, and I think there's a lot of work to be done, but that's where it would be very practical from a patient and clinical perspective.
Dr. Lansky, we have another question, but let me just follow up 1 second on what Tim said, because I'm not as much a pessimist about what we may be able to do in the future, and because of what you said in your last slide. So first of all, for me, heart failure and shock, it's not so, these paradigms we have are all how the patient adapts to the challenge. It's an adaptation. That's how we evolved, is to adapt to something. So every region in this country is probably different. In Canada, probably different to the adaptation. Insulin resistance in one area of Canada is going to be different than the other, and that's going to make a major impact on outcomes. It doesn't surprise me that C statistics are just not validated for that reason. But now comes the era maybe of AI where you may be able to take a general paradigm, do machine learning in your own, let's say, network. Like, for example, Geisinger has an amazing database with network. You could have a recipe of what you do for Geisinger patients. I'm hoping that's going to be the future. Sorry. Yeah.
Hi, this is Nikos Diagos from Texas Heart. I think what we forget is that shock is not being treated only in tertiary centers. So there are small hospitals, small units, small ICUs that are getting those patients, and they have to decide whether to transfer them or not. So I think this is very important for the risk score. So we keep thinking, the risk score is not going to help me. I have a shock team in my tertiary hospital. They're going to come, evaluate the patient. This is dynamic. We're going to put ECMO. We're going to upgrade, to whatever device. But I think these risk scores really help small hospitals when to transfer to the hub. And I think that's going to be a difference when we get to this risk stratification.
Yeah, no, I agree with that. Yeah, I think, Tim, you made the point about the what I call sort of like the third dimension, which is the trajectory. Right? What is the patient doing? Is the patient going, deteriorating, improving, or oscillating and sort of stagnating? And I think that's a dimension that we need to integrate to be able to understand their outcomes.
Thank you.
Yep.